practicing.
Thank you.
And now we've got Dripop Brahma.
Hello. Hi, I'm Dripop. I work in the area of health economics, maternal and child health, as well as health financing in developing countries. While I was working on this paper, I was a fellow at the National Institute of Public Finance and Policy. And I recently joined as an assistant professor at the Indian Institute of Technology in Jodhpur. So I will also be sharing my poster. Let me try that. Can you see my screen?
Yes, we can. Thank you. Your internet connection's just a little wobbly there. I'm not sure if there's anything at all you can do about that. People will be understanding, I'm sure, but just to let you know, it's sort of cutting out a little bit for me. Is that true for others, Yvonne or Robert or anyone else? Yeah.
Yes,
okay.
it's a problem.
Okay. All right. I don't know.
Virginia, quick,
yes.
I'm just wondering, to make it go smoother, would it be possible for you just to share all of the posters as we go through? Because then we don't have to have people turning on and off and.
Yes, I'd have to download them and save them. I looked at them straight off the screen. I wonder if, Sawyer, I don't know, by chance, do you have access, are you still there, Sawyer? Do you have access to the posters? I don't think he's back yet.
I think we could just share, you could probably just share posters with just for those who have, you know, bad internet connection, because what Robert suggests is because we were attending something and it's very hard together, and it's very hard when you have a bad internet connection to like see someone's screen and talk at the same time. But it works if someone else is sharing and the person who's presenting their videos off and they're just talking, so it just is smoother.
Okay. Yeah. So if I can manage it somewhere between the presentations, I'll try and particularly for Dripop D, I'll try and get your poster and have it ready as a backup if we need it. Okay, so thanks for that suggestion. We've just got a few more minutes. I just wanted to run through a few quick housekeeping items for everybody. So basically everybody's got about 2 minutes, but it looks like we have a couple of people, Ravi, and also, oh, okay, Brenda. I'm just looking at who's in the waiting room. So
yeah, that's my advisor.
Harley. Yeah, okay, let me admit Harley. Okay, all right, Harley, welcome. Can you hear me? It's Virginia Wiseman. Harley, can you hear us?
Hi, yes, sorry, I just got in.
That's okay. That's all right. We've just done a very quick introduction. We've only got a couple of minutes before the session starts, but welcome. I just wonder, are you sharing a screen for this session?
Yep.
And you're comfortable sharing a screen? You don't need to practice that?
Yep, it's fine.
Okay. All right. So I mentioned before that we have, it looks like 2 people in the session are not here. One is definitely not joining us, and that's Ravi. And it's possible, I think, that it looks to me like Grace is not there. So look, I try your best to keep to the sort of couple of minutes, because that obviously means there's going to be more time for discussion. But if, you know, don't panic if you're going over, you know, by a little bit. That's not a problem. I'm not going to dive in there. I will raise my hand when you're sort of in the last 30 seconds of your presentation. Don't be alarmed by that. It's just a sort of a small guide to let you know that you're sort of getting towards the end. And I'll sort of keep that. I'm just going to sort of flush it up there, but it will stay up once you've reached a couple of minutes. So you can, you know, sort of see that quite clearly. From my point of view, just in terms of the structure, so it looks like we have about 9 presentations. 1, 2, 3, 8 presentations now. 1, 2, 3, 4. Okay, 8 presentations. I'm going to suggest that we do, I mean, do you have a preference if we do sort of 2 at a time and then have some discussion after 2? Does that sound okay, or would you like to group them more than that? Okay. All right. 2 at a time. All right. Let's go for that. And then we can have, you know, sort of 5 to 8 minutes discussion after each of those sessions. We can also have a bit of time at the very end. Have you got any questions before we start admitting people to the session?
Am I correct that I'm starting?
Yeah, that's a good question, the order. So we've got, we actually had Dr. Suwando from Indonesia as the first person, but as you notice, he's not here. And then we have Stacey Arangi as the first person. We've got Stacey, then we've got Yvonne, we've got Harley, then it's you, Arushi. And then we've got Sochin Gan, we've got Dr. Zhao, we've got Grace, who's not yet here, no, and then Robert's at the very end. Okay, all right, shall we go ahead and let everyone in? Let's do that. Okay. Great, good. Okay, well, welcome everybody. I can see a lot of people are joining us second by second, which is great. Just to introduce myself, I'm Virginia Wiseman. I have a chair in health economics and health systems, both at the London School of Hygiene and Tropical Medicine and also at the Kirby Institute at the University of New South Wales. And I'm joining you today from Sydney, Australia, and I'd just like to acknowledge the land, the traditional owners of the land from where I join you, and that's the Gadigal people of the Eora Nation. And I'd firstly just like to say thank you to all of our speakers in case I run out of time at the end. I hope that you've had a chance to have a look at their uploaded presentations, their posters. A lot of work has gone into those, and we've got some wonderful work to be presented today. I just wanted to go through a few basic housekeeping rules with everybody. We've got, at the moment, we've got about 8 presentations for this session. It's possible that a couple of the missing speakers might join us. And these are from many different countries, locations around the world. This session is being recorded. You will have already probably seen that. Please make use of the chat box. I'm going to do my best at trying to kind of corral questions and feed those back to the authors, to the presenters. There's also live transcription going on. And if you're one of the people who find it a little bit annoying, whether you're someone who's presenting or listening, you can click hide subtitles in the live transcription button. We're going to do these presentations in batches of about 2 at a time, and have a little bit of discussion after each batch. I would encourage people as much as they can to turn their cameras on, particularly if they're presenting or if you decide that you're going to ask a question using the audio. Although I also understand that some people have limited bandwidth and they're going to be sort of mindful of that. We also would encourage you after the session to evaluate it. There is a simple button to press under this presentation on the IHEA agenda. The audio recording will be available 1 week following the end of the Congress on the Congress platform. If you have any issues accessing that, then just drop me an email and I'll share it with you or guide you to that. Okay, so we have about 75 minutes for presentations or summaries of the posters, and also some fruitful discussion. So what I'm going to do now is I'm going to hand over to our first presenter, and I'm just going to make sure, yes. So we've got Stacey Arangis from KEMRI, which is the Kenyan Medical Research Institute in Nairobi, a very, for those that not just work in Kenya, but all around the world. It's a very well-known institute. And I'd like to welcome you and invite you to begin your short 2-minute presentation. Oh, apologies, one last thing. We do have Sawyer with us. Sorry for not introducing you, Sawyer. Sawyer's from Conifex, who's going to answer any sort of, if you have any problems hearing, audio, presenting, just you'll see him in the list of participants and jot down your comment or question to him. Thanks, Sawyer. Apologies, back to you, Stacey.
Thank you, Virginia. Good morning, everyone. Allow me to share my screen. So I will keep my video off because of internet bandwidth, but I hope you can all see my screen. All right. So I'll be presenting on the impact of free maternity policies in Kenya, an interrupted time series analysis, and I'll be presenting on behalf of the listed co-authors. So a brief introduction is that Kenya introduced a free maternity policy in 2013 in all public facilities in Kenya, and subsequently in 2017, the policy was revised to what is now called the Linda Mama program, and this expanded access to the private sector, expanded the benefit package, and there was a change of management for better accountability. And the objective of our study was to evaluate the 2 free maternity policies using a quasi-experimental approach. So we used an interrupted time series analysis, and our time frame was from 2012 to 2019. The data source was the Kenya Health Information System, and we included all public, private, and faith-based facilities across the country that were part of the Linda Mama program. And we used a segmented negative binomial regression with seasonality to determine the level and trend effects of the policies. Just briefly on the results. So in terms of in public facilities, the 2013 free maternity led to a significant increase in normal deliveries and cesarean sections, and thereafter about a 1.4% trend decrease in cesarean sections. And both policies resulted in a significant level decrease in postnatal care visits, followed by a trend increase in the same. And there was no significant effect on ANC visits. In the private and faith-based facilities, we found that although the 2013 free maternity policy led to a level decrease in cesarean section, this was followed by a trend increase in the same, and the 2017 Linda Mama policy led to a decrease in normal deliveries and cesarean sections, and thereafter a trend increase in cesarean sections. Then the 2013 free maternity policy resulted in a level decrease in ANC visits, and there was no effect on both ANC and PNC. effect on the 2017 Linda Mama policy. So in conclusion, we find that the effect of the 2 user fee removal policies on maternal health appear to have been mixed. And this emphasizes the importance of addressing other service delivery issues, such as supply side strengthening, effective communication of the policies and clarity of the policies as well, ensuring effective provider payment mechanisms, and implementation fidelity, alongside removing the financial access barrier. And further, we also recognize that an increase in utilization of maternal health services may also call for a multi-sectoral approach to ensure that geographic accessibility is improved on. Thank you.
Thank you very much, Stacey. Now we're going to move straight on to Yvonne Bourget from the Institute of Public Health in Heidelberg, at Heidelberg University, Germany. Over to you, Yvonne.
Yes, good morning, everybody. Just allow me to also share my screen. Can you see it?
Yes, it's not in slide mode though.
I will switch to hard. Can you see the poster right now in slide mode?
Yes.
Okay, perfect. Yes, good morning, everybody. My name is Yvonne, and I'm working for the Heidelberg Institute of Global Health in Germany. And I'm going to present my poster, which is about leaving no one behind affordable, the case of delivering free primary care to the exempted ultra poor in Burkina Faso. So our objective was to estimate the cost of one single first level consultation and estimate the necessary budget to deliver primary healthcare services to the ultra poor in Burkina Faso, because we identified the knowledge gap that there is no cost assessment, and in light of this promise of leaving no one behind, it is essential to have a cost assessment on that. So we conducted a microcosting study in Burkina Faso and used medical records of over 1,000 ultra poor people, and we got data from 15 primary healthcare facilities, and then calculated the recurring cost per one first level consultation, and then used that as a basis to calculate the necessary budget for providing primary healthcare services to the ultra poor. So we calculated that on average, it cost about $2.2 to actually provide the services to the ultra poor, whereby the drug costs take up about 50% of the cost. And based on the cost per consultation, we calculated the necessary budget of targeting the bottom 20% of the population in Burkina Faso. And we estimated that one needs about $2.3 million that represent about 1% of the national healthcare budget in Burkina Faso. And in summary, we can say, yes, leaving no one behind is affordable, at least in Burkina Faso. And yeah, so that was our conclusion.
Great. Thank you very much, Yvonne. So we're going to just take a moment now to comment and pose any questions to our two presenters. I see we haven't got anything yet in the chat box. People are probably just warming up to that. But if you're more than welcome to use your audio if you'd like to speak. If it gets a bit complicated, I might need to take control of that, but very happy if people want to unmute themselves and put any questions or comments to Stacey or Yvonne. maybe I'll get things going. It always takes a little bit of time for people to get into it. But so maybe Stacey, if I could, it was a very nice presentation. I had a couple of questions. The first one was probably a question that you've thought a bit about, and that is how the exemptions weigh up against other out-of-pocket fees, and how, because we have seen a fair amount of research where exemptions to user fees have been removed, but we haven't seen a lot of change in utilisation or quality of care. I just wonder if you had any thoughts about that.
Thanks, Virginia. Yeah, so I think our study, when we're doing the analysis, we were expecting more to see more effects on the maternal health services, which was not really the case. There was some increase, but also some decrease, and this was both in the public and private sector, and this goes to emphasize the point that you've just mentioned, that although the services may be termed as free, there might be other issues that need to also be addressed to ensure that mothers have full access to these services. So for example, one of the things that we found out is that there was lack of clarity in the 2017 policy. Not only was deliveries free, but they included ANC and PNC, but there was a lack of clarity on there was a lack of clarity amongst the implementers that ANC and PNC was now free as well. So you'd find that as much as it's free according to the policy, there was implementation infidelity where as a result of the lack of clarity of the policy. So I think other issues also need to be addressed in addition to just ensuring, in addition to just having the user fee exemptions.
Yep.
Thank you. Over.
Thanks, Stacey. And another quick follow-up question from Naya. It says, great presentation. Were there differences in trends between urban and rural areas for any of the services after the policy was implemented? So that's another one for you, Stacey. We'll get to Yvonne in a moment.
Thanks, Neha. So in our current analysis, we did not disaggregate the analysis to look at the differences between urban and rural areas, but I think that's a good point for us to look into in future analysis. So thanks for that.
Okay. Thank you, Stacey. Yvonne, I'm wondering if I could just get your thoughts on a couple of things.
Yes.
One was if you could tell us a bit more about how you design scale up. You know, is that
Yes.
sort of just, were your costs sort of linear as you expanded the number of women? Did it sort of just increase, or did you adjust for fixed costs, for example? Could you maybe explain a little bit more about that?
Yes, so in this analysis right now, we only considered the recurrent cost, not the fixed cost. Then we tried to simulate how much it would cost to target 6% of the population, 9% and 20%. So for this analysis I was presenting, we didn't include the fixed cost at that stage because we were not there yet. But yes, during the time we also considered the capital cost, and yeah, definitely the capital cost, the cost per se, kind of decrease the more people are targeted. Yes, right. But it's not part of this presentation right now.
So do you think potentially there might be economies of scale could be an issue, or is there any reason for you to think that?
Economies of scale, you mean now that the more I target, the less cost would result from that?
Yeah, so for your fixed costs, the average cost might actually fall as you expand the number.
That is
Okay.
that is the case also here. The more we target, if we move from 6% to 20%, yes, then it's going to decrease per consultation.
Okay, great. Thank you. So this is continuing work for you. It's sounds very interesting. I think we're going to have to now. Oh, do we have a hand up?
I just
Yes.
have a quick question for Stacey if we have the time.
Yes, go ahead, and then Robert.
Stacey, just a quick question. You're using count data models. Is there a specific reason you use negative binomial and not Poisson or some other count data model?
Yvonne, I'm not sure if did you hear that question?
I think it was Stacey, not for Yvonne.
Oh, sorry, Stacey. Did you hear the question?
Yes, I did. So Arushi, you were asking, we're working with count data, why we used the negative binomial regression model.
Yeah, instead of other count data models such as Poisson or other models.
Yeah, so when we were fitting the data, the negative binomial model was the one that had the best fit when we compared the Poisson and the negative binomial model, and so we opted for that. And we used that because the variance was larger than the mean.
Okay,
that's good. Thank you.
Thanks, Stacey. And Robert, a quick one from Robert before we move on.
Yeah, thank you. So, Yvonne, I'm just curious, in your microcosting, I'm wondering if you accounted or how you accounted, or if you accounted for administrative costs, and then also potentially for transportation costs for the beneficiaries. Thank you.
Yes, thank you for your questions. We calculated overhead cost of 20%. We included that, but we didn't include the transportation cost of patients because we rather took the perspective of the health system and we didn't include the cost incurred by the patient.
Okay. Thank you, Yvonne. And I would say that if anyone wants to keep the discussion going, do post in the chat box, or we can follow up with each other after this session. So thanks, everyone. Now we're going to move on to our next two presentations. The first one is by Hali from Deakin University, Burwood, Australia. Over to you.
Thank you, Virginia. I'm going to share my screen now. So, okay. So you all see my screen? Oh, good. From beginning.
It's not, yes, we can see it. It's not yet on slide. Yep, perfect.
Yep. All right. Hi, everyone. Today I'm going to present the recent paper, Equity in Health Service Utilisation and Children Wellbeing. This is a result from an Australian longitudinal population-based study. So equity in access to and use of healthcare services is a national goal and a principal indicator of health system performance. And therefore, it is important to understand the association between socioeconomic position and healthcare utilisation, as well as children wellbeing. So the aim of this paper is to explore the association between children quality of life and also healthcare cost and SCP from 2 to 13 years. So the data used in this paper was from the longitudinal study of Australian children. This study includes both birth and kindergarten cohorts. So I use the birth cohort, which include roughly about 5,000 children from wave 2 to 7. For healthcare cost, I used Medicare data, which include biomedical and pharmaceutical cost. For children quality of life, was measured by the PESQL. The socioeconomic position was the composite measure of the education level, income and occupational status of the parents. So we use both multivariable linear regression and mixed effect model adjusted for potential confounder, including child age and sex, special healthcare needs, and remoteness of the family area of residence in the model. So the result of the model showed that in the first year of life, children from lower SEP families had lower healthcare utilization. But then between 2 to 13 years, children from lower SEP families seem to have potentially higher healthcare costs, but then have worse quality of life. So we found that child special healthcare needs and parental stress were associated with lower children quality of life and higher healthcare costs, whereas more sibling partner families and living in an inner regional areas were associated with better children quality of life and lower healthcare cost. So result from the study that's highlight the inequity in health service utilization and children well-being up to approaching adolescent, in particular in the first year of life. These findings have important implications for public health policy decision makers in efficiently planning and allocating resources. It's also important to consider the key predictor of healthcare utilization and children well-being when it comes to program design, like public health prevention and intervention. Thank you. So I'd just like to acknowledge the co-author and the family that joining in this study. Thank you.
Thank you, Ha. Perfect timing. Thanks very much. We're going to move on to our next presentation. And as I indicated earlier, we'll have some questions after these two presentations. So now we're going to hand over to Arushi Dhingra from Brisbane, Australia. I just wanted to also acknowledge her co-authors for this, Brendan Gannon, Luke Connolly, and Geeta Mishra. This is obviously a very collaborative piece of work. And over to you, Arushi. You're on mute. We saw your tongue.
Classic, yeah. I'm not gonna share any slides. I'm just gonna talk. So thank you. Well, as you said, I'm a PhD student at the University of Queensland, and my primary supervisor is Professor Brenda Gannon, who's also here with us today, I think. Today, I'll be presenting our paper on measuring inequity in less utilized health services. I particularly will focus on assisted reproductive technologies. Our research has three major contributions. First, we add to the literature by measuring income-related inequity in the use and financing of ART services. So since ART is a less utilized health service, it has a low mean, which brings us to my second contribution. So our second contribution is we use a novel econometric approach, which is penalized maximum likelihood estimator, or PMLE, to overcome issues such as separation that arise when maximum likelihood estimators such as logit and probit are applied to low mean outcome variables. Essentially, for example, if I use logit to estimate the use of ART, let's say if women in rural area never use ART, they'll be dropped from our sample if I use logit, which leads to sample selection bias. Hence, I use PMLE. I use two sources of rich data, which is survey data and linked administrative data from Australian longitudinal study of women's health, which is linked to MBS data, which is Medicare benefit schedule data. This is used to measure inequity. Our results show that there is pro-rich inequity in the use of ART services for the years 2009 and 2012, which means that after taking into account need factors, the use of ART is concentrated amongst the rich. We also find that financing of ART, in particular out-of-pocket costs, is progressive for the years 2009 and 2012. But what does this mean? It indicates that out-of-pocket costs as a proportion of income increases as income rises. Well, thank you.
Great, thank you very much. Excellent. All right, lots of things to get us thinking about. Any comments or questions from the group? I'm always ready to jump in, but I'd like to give others an opportunity. I can see Sophie Sheaf has got her hand up. Over to you, Sophie.
Thank you, Virginia. Thank you, Ha, for your presentation. So the question for Ha about the quality of life measurement use PET score in these longitudinal children samples. So I would imagine that you will probably use the proxy measure from a parent's report and for the quality of health-related quality of life estimate. But in some stage, whether the children whether children direct measures that children themselves report the quality of life being collected, or it's all proxy reports. So just a question about how you collect the health-related quality of life. And is the mixed method, I mean, if mixed collection method are used, how do you deal with that, quality of life reporting from either parents and children directly?
Thank you,
Thank
Sophie,
you.
for your question.
Good to see you here.
Yeah, good to see you, really, but not your face, really, just your voice. But because Sophie and I used to work together, like a few years ago.
Yeah, here you go.
Hi. So for this study, I only use the parent proxy reported because I think that for the early stages, like from wave 2 to wave 5, they only have that's parent reported. I think that also for LSAC, they only have parent reported. Usually for the PESQL, children are younger than 8 years cannot do report for themselves. So just the parent proxies. Okay. That's the only that are available that we use, across all waves. Like, so, for LSAC, a checkpoint, particular at wave 6.5, they actually also have parent reported data using the same PESQL. They also have other, like CHU9D, but for consistency, I only looking at the PESQL's parent reported.
Oh, okay. Thanks.
Thanks, Sophie. Thanks, Ha. So I wanted to ask Arushi about a couple of things. One was I'm really interested in the multiple data sets you used, and I just wanted to give us a few. There's always issues around data linkage that I'm sure you might want to highlight one or two there. And I guess I also just had a comment looking at the data 2006, 2009 and 2014. I just wonder where you feel things have gotten to now, if there's sort of been, if what you've sort of found using this data is, is it reflective of what's currently happening as well? Over to you.
Well, thank you for your question, Virginia. Yes, the data is quite rich and it was quite hard to access it. So it's survey data, which is from the Australian Longitudinal Study of Women's Health. It collects data from different age cohorts. So we have women who are, born in 1926, 1973, and so on. So I'm using one particular cohort, which is women born in 1973 to 1978. So during the time I'm using, 2006 to 2012, they're of maternal age. The average age is 28, 30, and yeah, so on. And this data is linked to MBS data, which is Medicare Benefit Schedule data. And this is collected by the Department of Health. So essentially, I have quite a lot of data on the number of services these women use, the exact fee charged by the practitioners, the benefit paid by the government, if the services were in hospital or out of hospital. So it's our out-of-pocket costs are quite accurate because we only focus on out-of-hospital services. In private health insurance cannot cover that. So yeah, so that's the data as you asked. Secondly, as of now, our data is a good representation of the national statistics because in our data, about 20% women are infertile, which is on average the national rate as well. And about 10% of those infertile women use ART, which is again quite a good representation. As of now, so there was a big policy change in 2010. So I think it has made ART a lot more expensive. So I think that there still is pro-rich inequity. Again, I would have to run stats for 2018, and once the new data set comes in 2021. So when I run it, I do expect to find pro-rich inequity as well, and progressive, because these services are very expensive. Yeah, hope that answers your question.
Yes, absolutely. Thank you. It's a really interesting study. We've got two comments, two hands up. I'll go to Sabrina first and then Taha.
Thanks, Virginia, and thanks, Arushi. Really interesting. I was actually just wondering, you said that you control for need variables. Which need variables did you control for? And did you also run the whole regression without controlling for need variables? And did you find that the inequality was even stronger then, or?
Great question, Sabrina. That's a very, very integral question when we do inequity analysis, because need is quite subjective. So for you, need can be different variables. For me, it could be different, but essentially, yes, I do. My need variables that I include are age, infertility, which is the big one. If women have endometriosis, which causes infertility, polycystic ovaries, I also include SF36 items such as general health, mental health, role functioning, and role emotional as need variables. Well, not including need variables and just including non-need variables and seeing the impact leads to omitted variable bias. So in order to see, how we have to first set the non-need variables to their mean values and then see how need variables are affecting the use. So it's quite complicated there, but essentially if I would have ignored the other variables, it would lead to omitted variable bias. So I haven't done that. Yeah, hope that answers your question.
Yeah, thank you. Very interesting.
Thank you. Great question. Over to Ha. Do you still have a question?
Yep. Hi, Arishi. Thank you for a very interesting presentation. I really like it. I just want to follow up the question from Virginia about the out-of-pocket cost. So just wondering, so you got the out-of-pocket cost from the link data, not the Medicare, because Medicare don't have that like out-of-pocket cost for private services, community services, on those sort of things. So it's somewhere else from the other whatever that link data you've got, but that's not self-reported data.
That is not self-reported data. I create my out-of-pocket cost variable from the link data. So essentially it's just cost of fees charged by the practitioners minus the benefit paid by the government. And I only do it for out-of-hospital services because by law, private health insurance cannot cover the difference. So I do not take into account in-hospital services because I don't know how much private health insurance is covering. So that wouldn't be correct. So yeah, I hope that answers your question.
Yeah, thanks. Just another question to follow up. So you don't have a lot of zero cost in your cost data, is that correct?
Do you mean zero fees?
Yeah,
yeah, if there are a lot of okay, essentially, yes, when I was cleaning the data, the fees were zero, but that's because there's a double entry to it. So I guess you're working with MBS data as well. That means there's a double entry that it was kind of a wrong entry. So there's a zero fees to counteract that. So if you check the services, you have +1 and -1. +1 is they use the service, -1 they did not use the service. And then that's when your fee will be zero. just to say that it was misrecorded, or there was a fault recording it, so then that's when your fee should be zero. So I don't have any zero fees because I did not take into account wrong entries.
Yeah, sounds good. Just because I want to, since Medicaid, you don't have that zero fee or zero cost. But I mean, like just for the other part, when you link data together, I'm not sure. But because it just, if you have a large amount of zero cost, you might want to consider some other, model to account for mass zero. That's all good. Thank you.
Yeah, no, thank you for that. Yeah, I will think about it next time if I have a lot of zeros. Or, yeah, thank you.
Great. Okay, thanks for your suggestions, Huh? We're going to move on now to our next two presentations. I'd like to firstly introduce So Chien Gan from the Ministry of Health in Malaysia, and also I think the University of Malaysia, if I'm correct. Over to you.
Thank you, Virginia. Hi, everyone. So I'm from Malaysia. I would like to share with you my research on evaluation of healthcare equity from the perspective of geography in my country. So we look at two perspectives. One is vertical and one is horizontal equity. The argument is we want to look at the availability of the healthcare resources, because we argue that the healthcare is static and it only serves the people at the vicinity. So when we look at analyze across the states, across the province level, we would like to have the healthcare resources allocated proportionally across the needs. We rank the population in their state level according to their states on the x-axis, and then we overlay with the concentration curve of the resources. If it comes out with the Kakwandi index, if it's approximately zero, it means it's the ideal situation. Secondly, we would like to look at the vertical equity, because in Malaysia, we have a mixed public-private system. So the public system is funded by the tax, almost free. The private system is funded by out-of-pocket majority. And the total health expenditure is around 50 to 50 over the country. So we argue that in the provinces that has higher, which is richer, they should have more private services. At that background, this time we rank the population according to the geography, but by their wealthiness, the poorer and the richer. And then we compare the concentration curve of the needs and the concentration curve of the resources of the public healthcare. So the argument would be the public healthcare should be concentrated among states which is less wealthy. The area between these two lines should be of a negative value. I call it difference indexes to indicate that we have pro-poor public sector distribution of resources. So I have gathered the data of expenditure hospital and primary care, and also the acute beds distribution of the hospital data. And across the 1997 and 2012, the horizontal equity is in place. Both primary care and hospital care are proportionate. For the vertical part, the primary healthcare expenditure is pro-pro, but the hospital care distribution resources wasn't pro-pro, except in 2020, the hospital beds of the public sector is concentrated in poorer states. Thank you.
Thank you very much. Now we're going to move quickly on to the next presentation and then take comments, questions after that. We've got now Yajin Zhao from Xi'an Jiatong University. Over to you.
Thank you, Virginia. Hello, everyone. My title is Impact of the Physician Remuneration System Reform at Public Hospitals in China, a Difference in Difference study. The first part is the introduction. The physician remuneration system in non-profit hospitals is a key policy lever to influence health system performance. The physician payment system offers challenges in reasonable salary structure and poor remuneration in developing countries. Chinese government piloted the physician remuneration system reform at public health hospitals in 2017 to change the salary structure, mobilize the physicians' work enthusiasm, and raise their salary. We aim to evaluate the impact of reform on salary structure and the salary level for hospital staff in China. The second part is the methods. We conducted a quasi-experimental design by using data of the China Physician Remuneration Reform survey at public hospitals in 2016 and 2017. In this cohort, 110,782 hospital staff covered 15 provinces were included in our study. Panel data analysis was performed with the propensity for matching with the difference in differences approach. So we can see the figure 1 presents the trends of the salary structure in the treatment and control groups before and after the intervention. Then, as shown in the figure 2, the matching performance between the treatment and control groups was good, and the two groups became more comparable at the baseline. The difference in differences analysis has been presented in table 1. We have found that the reform compared with the hospital staff without the reform, the percentage of annual base salary has raised by 0.47 and the percentage of annual merit salary has declined by 1.38. We have found that annual salary, annual base salary, and annual merit salary has been increased by 8%, 10%, and 8% respectively. In conclusion, our findings have significant and strong policy implications for China and low-income and middle-income countries to implement the physician payment system. Thank you.
Thank you very much. Two really nice presentations there, and perfect timing. So well done to both of you. Comments or questions from the group? Feel free to raise your hand or unmute.
I have a quick question for Saul. So do you conduct dominance testing, or do you do dominance analysis? Because I can see the concentration curve crosses, and that might change your results once you do dominance testing. Yeah, what do you?
I didn't manage to do it. I'm only using the 95% confidence interval. That's all I did.
Okay, so it sounds like something that might be worth considering. Thank you, Arishi. Any? I just wonder if I could also ask, follow up a little bit. So I'm wondering about this different index that you've used. Could you tell us a little bit more about how that's constructed?
So basically, because we have the two concentration index, we have the two concentration curve. There will be two concentration index. The difference in sex is just basically the difference between these two concentration index.
Oh, I see. I see. Sorry. Yeah, I missed that. Thank you for clarifying. Okay.
Thank you.
All right. I'm also wondering if I could ask Yajin a question as well. I wondered how important are the characteristics of jobs that doctors do in these types of analyses. I would imagine it's pretty important, the type of job.
Do you mean the characteristics of the control variables in my analysis?
Yes, I'm just thinking about, I think sort of the work that doctors do has been grouped. It hasn't been, I suppose, there's no differentiation between the different roles or the jobs that doctors do in this analysis. How important do you think that is?
Way to control the specialty education.
Yeah.
And the nature of the employment and the gender and the province level characters, such as the average social wages and the GDP.
Okay.
And the hospital level characters, such as the hospital level, hospital type.
I see. So yeah, all right, thank you.
Thank you.
Also, could I maybe just quickly ask, use my prerogative as chair to ask you another question? And this is just a much broader question about dual practice in China, doctors working sort of in and out of the public and the private sector. Is that relevant to your analysis? The fact that doctors are moving between those two sectors?
Sorry, I think this is a good question and is a good comment for me. But in our analysis, we cannot distinguish the moving of the private hospitals physicians and the non-profit hospitals physicians. We only have the data of the non-profit hospitals physicians, such as the tertiary hospitals and the secondary hospitals in China.
Right. Okay, no problem. Thank you. You can only do what you can with the data that you've got. Nice analysis. Thank you. Any other comments or questions from the group? I don't always see the way my screen is displayed. I've got a few screens going at the moment. I might not see your hand up. Any other comments?
Virginia, I had a question for Yashin, if I may. Thank you, Yashin. That was a really interesting presentation. I was just interested to know whether the increases in the proportion of base salary was similar for male and female physicians.
It's also a good question. But in my thesis, I don't focus on the sex differences in the proportion of the salary. So I think we'll do it in the future to check the differences between the sex. Thank you.
Thank you.
I think you're on mute, Virginia. We can't hear you.
I'm back. Any final thanks? Any final questions? No? Okay. I think I had to do that once, at least once during the session. Now it's over. All right. Thanks again to both of you. Now we're going to move on to our final two presentations. The first presentation is by Dwipapti Brahma from the National Institute of Public Finance and Policy in New Delhi. Over to you.
Hello. I'll try to preserve the internet bandwidth, so I won't turn on my video, but I'll share my poster. Okay. So this is joint work with Professor Meeta Chaudhary, also at the National Institute of Public Finance and Policy. This is titled More Health Per Rupee, Efficiency of Public Spending and Governance Quality. So in this study, we look at the technical efficiency of public expenditure, public health expenditure across the states in India. So in India, public health decisions are primarily taken at the state level. This is as per the constitution because health is a subject on the state list. So this creates interesting variations in the efficiency of public spending in health across the states. So we do two things in the study. First, we combine a set of administrative data to calculate the technical efficiency of public spending across the states. And we identify most technologically efficient states. We also identify the least technologically efficient states. And we use stochastic frontier models to do this. And since there is considerable variation in how funds are disbursed across large and small states, we also run separate analysis for the large states and the small and hilly states separately. And from this step, from the stochastic frontier models, we get the values of technical efficiency. We use those to rank order the states. And in our second step, we use another administrative data set, which is the delay in the number of days in funds disbursed from the treasury to the state health societies, as well as the vacancy in the healthcare workforce, so doctors and nurses in the public health centers. And we regress the technical efficiency estimates that we get from our first step onto the delay and the vacancy in the healthcare workforce. And as a result, we calculate the marginal effect of the delay on technical efficiency and on healthcare workforce vacancies. So we find that the most technically efficient states are some of the large states and southern states like Tamil Nadu, Kerala, West Bengal, Uttar Pradesh, and Rajasthan, whereas some of the least technically efficient states are Haryana, Punjab, Assam, Chhattisgarh, and Jharkhand. In terms of the estimates, we find that an increase, a 1% increase in the per capita public health expenditure in health increases per capita patients treated by around 4% nationally. Tamil Nadu stands out as the most efficient state, and whereas Nagaland, a small state in the northeast, stands out as the least efficient state. In terms of looking at the effect of delay, we find that a delay in funds disbursed by 1 day can decrease the efficiency of public spending between 0.7 to 1.4%. Contrasting that with the effect of healthcare worker vacancy, a 1% increase in healthcare worker vacancy decreases efficiency between 1.1 to 3.8%. Thank you.
Thank you. That was great, and no problems at all hearing you. Perfect.
Great.
All right. We're going to move on to our last presentation, although I will just do a quick check at the end to make sure our two other presenters aren't somewhere in our virtual room and I've missed them. But now I'm going to hand over to Robert Collisar from Apt Associates, Phnom Penh in Cambodia. Thanks, Robert.
Good day, everybody. I'm working with Apt Associates as an embedded advisor to the Cambodian Ministry of Economy and Finance. And I'll be sharing summary preliminary results from our study on public health services technical efficiency and applied cost allocation in Cambodia. So we used output-oriented data, bias-corrected data and development analysis to assess technical efficiency of public health services and estimate the potential for increased service output with current supply-side financing at both the hospital and health center levels. We then use the service-specific data for utilization rates, unit costs, and increased output production potential calculated from the technical efficiency scores to estimate the potential additional social health insurance beneficiaries that could be enrolled and served by the public health system if it were fully efficient. We estimate that there is a service space to cover more than 3 million new beneficiaries, or approximately 20% of the population. In relation to the unit cost estimates, we use Almond-Shapley applied cost allocation, and we find there to be some misalignment between social health insurance service payment rates and unit costs. To the best of our knowledge, this is the first time this method has been used for health services costing, and we believe this approach to be a good alternative to traditional costing studies, which can be very labor intensive, time consuming, and resource intensive. In conclusion, Cambodia's public health service efficiency can be improved by increasing utilization. And this can be achieved by enrolling more people into the social health insurance schemes. Moreover, shifting financial resources to the demand side through service reimbursements and increasing and realigning the payment rates would likely incentivize increased service provision. Thank you.
Thanks, Robert. Congratulations, firstly, to all our presenters. They're really very clear presentations, and you've all done very well at keeping to time. So thank you. Okay, any comments or questions? I can't see any hands up at the moment. So I might, while you're still thinking, I might jump in there. Robert, I'm sure that this is going to come as no surprise to you, but I'm just wondering about the informal sector in Cambodia. Are they still not included as part, could you maybe, of the health equity funds, could you explain a bit more?
Yeah, so the health service sector is dominated by the private sector. Only about 20% of the population first seeks care at the public sector, and then for second visit it goes down from there. And so there is an ongoing discussion around the role of the private sector. It is at this time it is currently basically unregulated. Folks may be aware that typically within a DEA analysis, you do what's called a second stage analysis, which you analyze your efficiency scores as your dependent variable. And we actually have, we've started that analysis, and we found that there's only two, after controlling for population size, there's only two variables that show that are impacting on the variation in these technical efficiency scores in the public sector. The first is quality scores for the public sector, summarized or aggregated at provincial level, but separated out by hospitals and health centers. And the second one is private sector. And so there's a small amount of private sector providers, small scale private sector providers that actually have a highly statistically significant positive impact on public health sector efficiency scores. However, it's very tiny, and then it's a nonlinear relationship. So it reverses, and then the more private providers that you have within a province, it corresponds highly significantly to a deterioration in public sector efficiency, which is most likely the consequence of them pulling away patients from the public sector. Thank you.
Thanks, Robert. Any other comments or questions from the group?
Yeah, I got a question for Wibori, sorry, I can't pronounce the name. So just wondering, did you look at the efficiency of public spending between rural and urban area? And I guess because, I mean, like the concern is that there might be like oversupply in the urban area rather than rural areas. And then I'm just wondering if you can give me some explanation of what are the factors that explain why Tamil is the most efficient like hospital or whatever public spending in that region compared to the rest of the other states. Yeah, so that's two questions for you. And then one question for Robert. I'm just wondering, because I'm not very familiar with the health system in Cambodia, just wondering, so you're saying that one of the implication or recommendation is trying to enroll more health service utilization in the population. So is that, so I'm not sure if there is a universal healthcare scheme there, or like what is the eligibility for people to be enrolled into the social scheme health system whatsoever there. So I'm just wondering whether there is some barriers to access services like other public costs or other things, even though that they don't have to pay for the services, but then transportation or food or whatever else there that sort of prevent them to access services. Thank you.
Okay. Thanks, Ha. So we have two questions, one for each of our presenters. Dwi Popati, did you want to tackle the first question?
Yeah, I'll go first. So those are really two very good questions. So on the first one about the differences in rural and urban areas, unfortunately, we don't have administrative data on public spending disaggregated by rural and urban areas currently. We only have it aggregated at the state level. So we don't see the difference in rural urban areas currently, but it's certainly something that we'll try to explore in the future. In terms of looking at why some of the states are more efficient than others, that's partly due to the governance quality in these states. So some of the southern states like Tamil Nadu just have an overall better health system. So one of the variables that I looked at in the second part of the analysis was the delay in disbursal of funds. And so the southern states have less delay in disbursal of funds through the various levels of the government. So the health centers just get the funds sooner than some of the other states, and so they're able to spend it as per their wish. That's one of the reasons why states like Tamil Nadu is more efficient than, say, Nagaland.
Thank you very much. Did you want to follow up on that, Ha? Is that you're happy with that response?
Yeah, that's good. Thanks. Yeah, that's good.
Thank you, Dwi Popati. And now back to Robert. Robert, you're on mute.
I'm sorry, I'm trying to share a slide that will help me explain or to respond. So basically there's 4 social health insurance schemes. You have the civil servant scheme in the yellow. Then you have the private employee scheme, which is only for the private employee, not their family as of yet. There have been a few little extensions to the Health Equity Fund, which is really small. And then you have basically the Health Equity Fund, which covers the poor. And so there has been an extension to this program during the COVID period to reassess enrollment, and they have increased the number of people that are eligible for those free services by about 600,000, so not completely insignificant. And then you can just see, I want to highlight the red, which is what we estimate the potential expansion to be with current supply side financing. I think in relation to the second part of your question, I believe one of the reasons why we undertook this study is because there seems to be a chicken and egg problem with expanding population coverage in Cambodia. And so on the one hand, you have the people who are the high level decision makers who are saying that they're not quite sure the public system is giving them a bang for their buck. They're not getting value for money, and they're not convinced that it's a good idea to add money into the system. And then you also have on the other side, the high level people within the Ministry of Health that are arguing that, well, we're happy to expand social health protection and services. However, you need to increase our budget to accordingly. And so one of the ideas behind this study was trying to break that kind of gridlock and just shine some light on what and quantify the inefficiency in the system and the potential for current services. And there are mechanisms by which people could be enrolled. Actually, they're quite okay with on that side of it. Over.
Thanks, Robert. I guess maybe I can't see any other hands up. I just want to quickly ask you, Robert, DEA, I've never done one. I've had students and colleagues that have, and I've always been apprehensive in thinking about the data that is needed to do one. What would you say to people like me? You know, am I right to be concerned about the sort of granular data that's needed for DEA, or not such an issue?
Well, I mean, data is always an issue, no? So we decided to focus our unit of analysis, or we call it the decision-making unit in DEA talk, at the provincial level. And we did that because one, it does facilitate the data. A lot of the data is being reported at the provincial level. However, we also did it because on January 1st, 2020, a new directive came from the Prime Minister, fully decentralizing responsibility for both budget execution and results within the health sector to the provincial governments. And so this also serves as a baseline, because we used 2019 data because we didn't want to have the, there's research that shows that there were a lot of anomalies with care seeking in 2020 due to COVID. And so we just wanted to focus on kind of a normal situation. What is the normal budget, and what did the normal service delivery look like? And so I would argue that, I would argue that there's some advantages, and we use this applied costing approach and benchmarked it against a very high quality, detailed costing study that's ongoing. And our results are not so far off. And so I think if you take into account the time and effort that's required to do, like, a gold standard costing study, you can get relatively reasonable results in a very short period of time by looking at aggregate data and then distributing all of your costs that you've accounted for as your inputs along your output axes.
Okay.
Over.
Thank you. All right. Well, thank you very much to all of our presenters today, and to also all of you who've joined as part of the audience. Just a couple of quick wrap-up comments from me. One is that to remind you that two things. One is that these presentations, these posters, will continue to be accessible to all of us well after, I think for quite a few months post IHEA. So you can easily access them anytime if you haven't already. The second thing is that, and I flagged this earlier, there is an evaluate button on the program, and you can click it. It's next to this session, and we'd encourage you to do that. And I think all of the presenters would be very open to contacting them if you have any further suggestions or comments. If you go again, you look them up on the program, there is a messaging box for each conference participant, and you can use that. So once again, thanks a lot, everybody. It's fantastic. I just also want to acknowledge there were a few presenters who weren't able to join us. And I know certainly our colleague in Indonesia, they are going through an incredibly difficult time right now with COVID, as in many countries, but Indonesia this week has been, it's just been crazy. So just to acknowledge that there are a few presenters who couldn't join us, but their posters are also available for you to have a closer look. Okay, well, thanks a lot, everybody, and enjoy the rest of the conference.